We give them 4 more minutes. We start at 7:10.
I think we can start. I see we are well over, we're almost clocking 400. Good evening and karibuni sana to this webinar. Today's webinar is on current management of hypertension. My name is Ivy Ratemo, PGMT from PSK. I will be your host for today. Today's webinar is sponsored by Boehringer Ingelheim, and our speaker for the day is Dr. Martin Wanyoike, who is a cardiologist. Let me tell you a little about our speaker before he comes on. Dr. Wanyoike holds a MBCHB and a MEd in internal medicine from the University of Nairobi. He has been practicing medicine for the last 34 years and cardiology for the last 28 years. He also underwent cardiac training in Netherlands, India, South Africa, and the United States of America. Dr. Wanyoike runs Primecare Heart Clinic, which is a hospital-based cardiology and internal medicine clinic located at Anderson Medical Center in the Nairobi Hospital. For this webinar, we have a few ground rules and announcements. First things first, I want to thank you all for participating and joining in this session. I kindly ask all participants to be muted during the entire course of this session. Please type your questions under the Q&A tab. It's at the bottom of your window. The questions will be addressed by the presenters on the tab, and we'll also have a Q&A session where they'll answer the questions live. For PSK members, if you've not already done so, please subscribe on the PPD portal for the conference so that you can get your CPD points. For KPM members, the attendance list shall be shared with the officials for the awarding of CPD points. Note that this session will be recorded and made available on our YouTube page. Thank you and karibuni. Dr. Wanyoike, please share your screen. And karibu sana.
You can see the screen?
Yes, Dr. I, we can see you.
Yes, we
so
can.
I can actually start. So
yes.
Good evening, everybody. I see there are quite a big number of participants. I thank Boehringer and the Pharmaceutical Society of Kenya for inviting me to do this presentation. It's a wonderful experience for me because this is an opportunity also to interact with the pharmacists so that we yes, it's my IT person who was just adjusting the slides again. So I believe I'm live and I'm being seen. So I say it's a great opportunity for me to share with you what we do as cardiologists, and also an opportunity for us to interact with you, because what we always say is that when you're managing hypertension, it's really a teamwork where all the medical personnel are involved, and the most important person in this management of the patient is that one who prescribes the medication and the one who dispenses and explain to the patient. And we know there are many times, even us, when we are even having worked for so many years as doctors, we may make mistakes in the prescriptions. And it is you people now in the pharmaceutical industry, the one who are giving out the medicines, who can actually audit so that those errors which may occur to human issues, you are able to correct them for us. For example, say if your patient is in the childbearing age, she's expecting and is taking, say, a drug like ACE inhibitors or ARB, and we know they are contraindicated, that is an opportunity for the pharmacist to actually intervene and help that particular patient. So when we are discussing about high blood pressure, the main topics which we really do when we do presentation is like this one, which is a general one on hypertension in general. There are times when we focus on hypertension in critically ill patients, and that is what we call hypertensive crisis, where you deal with the pressure where the pressure is, say, above 180 over 120 and above, how we manage those patients. There's also another category of hypertension, which we refer to when you are using more than 4 drugs, 3 drugs, and you're not reaching the goals, and that is what we call resistant hypertension. But this is a simple one of them all, where we actually just do at the general issues related to hypertension. Anybody who interacts with the patients deal with hypertension. And all over the world, including Kenya, this is the most common medical condition in clinical practice. And we know that as we get older and the population get older in this country, you'll be dealing even with more hypertension. And what is known from those people, those countries where they have documented the medical care properly, we know that usually when the people start taking salt and they reach the age of 40, about 20% of people at that age have high blood pressure. When you reach the age of 50, it is actually about 30%. At 60 years, it is half the people, so 50% of people get high blood pressure. And we actually say in medicine, if you live long enough, you are going to get high blood pressure, such that if you are blessed and you reach the age of 80, almost 80% of people that time will be having pressure. By the age of 90%, so that we say if you live long enough, you are going to get high blood pressure. And the blood pressure needs to be treated for mainly to reduce the morbidity and mortality related to the blood pressure. When we are talking to the lay people, we tell them that hypertension is a silent killer because you don't present with any symptoms. And the times when you know that pressure is present is when there is target organ damage present, and that time is usually too late for intervention. So all those things are issues which we need to take in the background as we look at this topic. So the references, of course, those ones who are in clinical practice and you want to practice well, the way we do when you're not in academic is using guidelines. And the guidelines are coming so often. There is this one for the American Heart Association, American College of Cardiology 2017. Those guidelines, if you read them and practice them, you are doing very well in management of blood pressure. The journal we usually use in internal medicine called New England Journal of Medicine, which is free in this country. There's a review article there, which also is part of the reference today. Then there is a European Society of Cardiology, which we usually do pilgrimage before Corona came, but now we are not able to go to Europe for these conferences. And they usually give guidelines after so often. There was one of 2013 now, the latest one is 2018. Then the International Society of Hypertension, Global Hypertension Guidelines, which were 2020, they are the latest. But when you look at 2017, 2018, 2020, there are really no major paradigm shift on the pressure is managed, and really the way it is has not changed much. And we consider that high blood pressure is part of that equation we learned in high school, the Ohm's law, that voltage is equal to current times resistance. And blood pressure itself is a product of cardiac output. I don't know where the background noise is coming from. Somebody has not muted the microphone. Just check whether all the participants yourself, you have muted the microphone. Anyhow, so the blood pressure is a product of cardiac output multiplied by systemic vascular resistance. And when we are treating hypertension, we are mainly manipulating the equation of systemic vascular resistance. Then the cardiac output is a product of stroke volume times heart rate. And we may not need to go to the science of that at this stage, but that is where the equation of blood pressure is derived from. Now, when we define blood pressure today, we say blood pressure is high when we find it above 130/80. And this is according to, so somebody is moving in the background, there's so much noise. So please, if you are participating, switch off the microphone because you're disturbing the other people. Now, the blood pressure will be defined from the American Heart Association when the pressure is above 130/80. There are people who define it as high when it's above 140/90. We prefer this one of 130/80 because this is where we start treating the pressure. This is the target also. And the figure of 130/80 is very key for anybody managing blood pressure today. Because in the past, used to talk of a target of 140/90. But the latest guidelines talk of 130/80. And even whether you're having chronic kidney disease, whether you're having diabetes, the figures still remain at 130/80. But the damage to the blood vessels, which is the main cause of morbidity and mortality in people with blood pressure, is when the pressure is above 115/75. You may also need to also take into consideration there are situations when we say the pressure is over controlled. And a patient who is not having diabetes and less than 60 years, when the pressure is below 110/60, then that pressure is over controlled. And this is an opportunity for scaling down on the medication. Whereas when you are at an age of 60 years and above,
allow me
the
to,
pressure, yeah.
Doctor, allow me to interrupt. Please share your screen.
Mine is not
Participants are not
seen.
able to see it properly.
I do it again.
Yes, kindly.
Let me do it again. I'll stop sharing and then I do it again.
Yes, thank you, Dr.
My IT man came and so share screen.
Also, kindly mute your mics. Participants, please kindly mute all your mics. Thank you.
Are you able to see it now, Dr. Ratemo?
Yes, I'm able to see it,
So
Dr. Carry on.
that is okay. So we are seeing when you're treating blood pressure, there are those targets for the lower side. And those are also very important because when you control the blood pressure, especially for the elderly patients, that may also increase their morbidity, mortality, fainting episodes. And we should not keep it below 120/720 or more than 60. And then there's the same figure we also give for the people who has diabetes. Those studies done in diabetes show that the outcome of patients is not good when you keep it below 120/70. So I think I have to put them again because I have seen they were not moving. So share screen. So let's see. Are you seeing me now?
Yes,
Dr. Ratemo? Yes.
Yes, you can see the
somehow
screen.
are not moving forward. I don't know why they have refused to move forward. But at least I have an IT man with me.
That's okay.
I think we are okay now. Are you sharing? Are you seeing the slides?
No, Doctor, we can't see your screen.
Man is going to have somebody here who is really. Are you able to see?
Yes, Doctor, we can see the screen.
Fine, we can continue. So yes, the next slide you have put there is the way blood pressure is measured. Of course, when you are like in a pharmacy setting, any recording of blood pressure is useful for the patient because it gives us a clue. But we even tell patients when they measure at home, when the pressure is out of the range, they should have it verified so that it's done the scientific way. And you can see this gentleman who is seated, the feet are flat on the floor. He's supported by the chair and the arm is resting on the table. And the patient is not talking between the measurements. The curve must fit the size of the arm. So there are small curves, usual and large. And the arm should be bare. And so they should not be having a tight dressing on it. And the blood pressure is ideally done when you are in a quiet room, a comfortable temperature, no smoking, coffee, or exercise for 30 minutes before that is done. The bladder should be empty and the patient will relax 3 to 5 minutes. And that overcomes that very common condition we call white coat effect. And you should take 3 minutes at 1 minute interval. And the average of the last 2 measurements are the ones you take. So there's a science on even for measuring the blood pressure. And it requires a lot of time. And of course, I know, like if in your pharmacy setup, you're busy seeing other clients, you are measuring in a hurry. When the pressure is out of the range, that's the one you should even take more interest. When the pressure is either too low or too high, that you try to do it in that ideal way. Then, of course, this is a classification of blood pressure. This is according to the American Heart Association, and that's the normal pressure is less than 120/80. We say elevated 120 to 129 systolic and less than 80 diastolic. And then stage 1 is when it is 130 to 139 systolic, 80 to 89 diastolic. and stage 2 is when it's above 140/90. And then, of course, there is that what we call isolated systolic hypertension, where the systolic pressure is high, but the diastolic is less than 80. And also that one needs to be managed, still with the same targets, because it's also associated with some morbidity and mortality. So for hypertension, this is a slide of 2003. Things have not changed much in the world, because the awareness still in Western countries where they do a lot of studies is about 70%. So 70% for people with high blood pressure are the ones who know that the pressure is high. The ones of treatment is 60%, 30% are control, and the adequate control in the diabetic when used to target 130/80, when the other people are 140/90 was 10%. In Kenya, we do so badly, so that even awareness is estimated to be about 30% in this country. Probably it's only 10% who are on the pressure medication, and the ones who reach the target probably are less than 3%. So we are doing very, very bad, and we need to join arms together so that we can at least increase awareness, increase people who are at the target, and also making them understand about the blood pressure. So why do you need to treat the blood pressure? Of course, the need for treatment of the blood pressure is to avoid that target organ damage. And the target organ damage start in the brain, strokes, in fact, dementia. One of the ways in which you motivate patients to take medicine for pressure is to remind them that when you are having high blood pressure and you don't take the medicines, then by the time you reach the age of 60, 65, when you have grandchildren, you will be forgetting their names. And dementia is one of the causes for those people who the pressure was not treated. There's that affection of the eye. The heart is the one where there is more damage. And we know in Africa, where Kenya is part of it, sub-Saharan Africa, the most common cause of a weak heart is pressure which was not controlled well. And as you're going to see in the slides ahead, high blood pressure initially causes the left ventricle to become hypertrophied, thickened, and scarred with fibrous tissue. And the patient at that stage have what is called heart failure with preserved ejection fraction. That's when you do an echocardiogram, the ejection fraction is normal between 55 and 70. But that type of patient with hypertrophied ventricle, as you're going to see, the ventricle is not able to receive blood from the veins and the pulmonary veins, and that causes congestion and you get heart failure. Then eventually, as the damage of the myocardium occurs, the myocardium becomes thin and the ejection fraction reduces. And when it's below 35%, then we say a patient has heart failure with reduced ejection fraction. Kidney damage occurs, and we have seen many people going for dialysis, and the reason why they are required that dialysis, which can only be salvaged by a kidney transplant, is because there was a pressure which was not controlled, because when the pressure is not controlled over time, kidney damage occurs. The vasculature also occur. You may get aortic aneurysms. You may get peripheral artery disease where you're required to do amputation for the limbs because the pressure was not controlled on time. So the management of pressure more is so that you avoid the target organ damage, because that's what causes morbidity and mortality. But we know that even some people walking up with pressures, and we have seen them even in this practice where somebody may come with a pressure of 200/130, and they are still normal and feeling okay. But those type of patients, when you don't bring the pressure down, the target organ damage within a year is so much, and many of them may be lost. So for the management of blood pressure, you need to consider a high-risk patient. And a high-risk patient is that one who really has this lifestyle syndrome. And people with lifestyle syndrome are people enjoying their life. They have taken excess calories. They are physically inactive. They have a lot of stress also, because sometimes they are giving themselves very high targets, especially when they want to be rich and wealthy and influential. They become overweight. There is obesity. That is a person who is very likely to have blood pressure. When you're also a smoker, the risk is also more. And the damage to the organs you even become more when you're smoking. Those people who take dietary, which is high in fat, salt, and low in potassium, also at high risk. But there's high intake of alcohol, and that is more than 2 units for male and 1 unit for a female per day. That one also increases the risk of blood pressure. When there's a family history of high blood pressure, when there's a family history of premature coronary artery disease, when there's a family history of diabetes mellitus, those people are more likely to get high blood pressure. Premature coronary artery disease will mean somebody getting angina or coronary artery disease where you are coming with acute myocardial infarction, acute coronary syndrome, or bypass before the age of 55 male, 65 female. That is premature in the family. There's a concept we refer to as rift gene hypothesis, where we say that in those communities where there is a lot of starvation over the years, their genes are programmed that when they reach a point where those individuals are able to get the food they want, they tend to get a lot of preservation of their calories, and they get a lot of weight, especially in the abdomen, because they are preservers of calories, and that weight in the abdomen leads to what is called metabolic syndrome, and that leads to high blood pressure, diabetes, and premature death in the future. Then the thrifted gene phenotype hypothesis is those situations whereby the intrauterine life, when the baby is underweight for whatever reason, or the first years of life is starvation, the genes of those patients are programmed that they conserve energy very easily, so that again, when they reach a point where somebody has gone through the university, there's buffet for breakfast and lunch and dinner, then that calorie taken to a lot of excess become over manifested, and overweight comes in that individual, and then that causes premature death also. So how do we manage blood pressure? The principles of management of high blood pressure, we have actually six principles of management. First of all, when you diagnose a patient with high blood pressure, it is very important to take a lot of time in patient education and motivating the patient to take medication. Many patients know that drugs are poison, they poison the body, and many of them actually believe that if you're taking the high blood pressure medicine, then you are risking damage to your kidney, to your liver, to your brain, to your heart, and they think that the medicine themselves are the ones which are going to cause damage. But we keep on telling them that the damage to the organs is the blood pressure level. When the pressure is above 130/80, that's what is one going to cause damage. So spend a lot of time giving the patient information so they understand what the pressure is, why it damages the organ, how it damages the organs, so that they can be part of your team. Because these are long life treatments, and you can only succeed when you're a team. Then for every patient you see, you need to identify the target blood pressure. And like the guidelines as they are today, really we are aiming at 130/80. And what we tell patients is that let us try to keep that pressure at 130/80 or below. But we still say that at 140/90, because sometimes to achieve those targets is quite an uphill task, where you have to use multitude of medication, we still can accept, and we accept at 140/90 as still acceptable blood pressure. But especially those people who are less than 60 years old, keeping them below 130/80 helps, but try to avoid to keep it below 110/60. Then you need to identify for that particular patient with blood pressure, you need to identify contributing factors. And which are the contributing factors which bring about high blood pressure? Is the lifestyle adherence, taking a lot of salt, not exercising, being overweight, and also being sedentary, that you trigger the pressure to even be perpetuated. We need also, when you are seeing a patient with high blood pressure and the management principle, you need to identify secondary causes. Remember that 5 to 10% of people with high blood pressure is secondary to something else. And those ones, secondary causes, sometimes the drugs don't work. Sometimes secondary causes, if you address the secondary cause, then you can actually have the patient stopping the medicine. Then also remember the interfering drugs. The most common are non-steroidal anti-inflammatory drugs, those ones used for joints. And you know, those people who reach the age of 60, better when the weight is high, they have overloaded their joints. Most of them have osteoarthritis, and osteoarthritis, they are taking diclofenac, brufen, and all that. And those, you increase the blood pressure by themselves. Then when you are even those people who manage themselves, self-medication of drugs like steroids for those people who have asthma. The steroids also, the prednisone, there are many preparations we have in this country. And when they are used long-term, they can also bring about making sure the pressure getting up, the steroids. Then in a patient who has high blood pressure, it's very important to address number 4, risk factor, the cardiovascular risk management. Most of those patients with high blood pressure at least have 1 or 2 cardiovascular risks. And which are these cardiovascular risks? It is having overweight, it is having diabetes mellitus, it is being a smoker, it is having high cholesterol, and it is having overweight. All those need to be taken into consideration, because if you just control the pressure and the patient continues smoking, continue living with very high cholesterol, continue having diabetes, and the sugar is not to the target, then they are still going to get mortality and morbidity from the blood pressure. Then number 5 is therapeutic lifestyle changes. This is where you're encouraging the patient to exercise, to reduce weight, to reduce salt, to reduce alcohol intake, and to take even diet which is very high in fruits and vegetables. And as you're going to see later on as we go along. Then the final point is where the pharmacist and the doctor come in to give the prescription. So you have to do 1, 2, 3, 4, 5 before you prescribe. because the drug is the final part, and that need to be done when all these factors have been considered. So in a patient who has high blood pressure, the part of evaluation when you're doing the history, physical examination, and laboratory data, you are trying to identify that high-risk patient. You are trying to identify cardiovascular risk factor in that patient. You also need to reveal identifiable causes of hypertension, that's secondary hypertension. And then at the time of evaluation, you are working very hard to detect target organ damage, because it's the one which causes morbidity and mortality in your patient. So in a patient who has high blood pressure, the basic test we need to do is need to do a sugar, make sure they don't hit diabetes, complete blood count. Many of them may be having complications related to hemoglobin, and that affecting even their profiles. Lipid profile is a very important aspect, because that is the way you can profile them, whether they have any cardiovascular risk related to the cholesterol. The kidney function is very important. There are some drugs which you cannot use when the kidney function is poor. There are others who can make kidney function worse. And knowing where the kidney is very important. We also know that when you have kidney damage to whatever cause, if you have a primary kidney disease, that kidney disease also will lead to secondary hypertension in that particular patient. So addressing and identifying that the kidneys are functioning is key. The electrolytes, sodium, potassium, calcium are important. Calcium will help you identify the patient who has hyperparathyroidism, which is one of the causes of secondary hypertension. When the potassium is low in a patient who has hypertension, we always consider whether they are having this aldosterone overproduction, and those are the patients who benefit from using the drugs like mineralocorticoid antagonists. And these are something we find very common in those patients who have secondary hypertension and they have also resistance hypertension. Sodium level also very important, because many patients, especially those ones who are on Zazide diuretics, they start to get very low sodium. Remember, everybody in Kenya believes, especially our nice ladies, they are always carrying bottles of water. So people are taking so much water that the sodium is very low. And when they're already taking the Zazide diuretic, the sodium gets to be low, and that causes its own morbidity and mortality, mainly morbidity. Then thyroid stimulating hormone, we need to check. Urinalysis, electrocardiogram, ECG we do, like in our clinic, we do as a routine. Echo, uric acid, urine, and albumin is also part of that evaluation. And you need to look for those cardiovascular risk factors, that is smoking, diabetes, cholesterol problem, overweight, physical inactivity, and healthy diet. You need to look for chronic kidney disease, family history, so that you know how much this patient has, increasing age, low socioeconomic status, male sex, obstructive sleep apnea, which you talk more, and psychosocial stress. So the pathogenesis of hypertension is actually related to people who take excess calories, who are physically inactive. It leads to obesity. And when there is obesity, and especially fat in the abdomen, that one between the intestines, it is the one which causes havoc to the body, because fat in the abdomen releases free fatty acids, tumor necrotic factor, interleukin-6. These are the ones called cytokines. They're the same ones released by patients who have heart failure. That's what makes them wasting. The same chemicals produced when you have cancers. And these cytokines, they lead to increased clotting tendency. So the patient with the metabolic syndrome, overweight, is having tendency to form clots. The cholesterol becomes deranged, so that they have a more dangerous cholesterol in their body. And then also these chemicals also cause inflammation in the blood vessels. They make also insulin not work. So you start getting insulin resistance. And in insulin resistance over time, you get glucose intolerance, and then that eventually leads to diabetes. Then that excessive insulin circulation causes salt and water retention. It increases sympathetic tone, so that the heart rate goes up. There's also smooth muscle hypertrophy, and that leads the patient to have hypertension. So because of overweight and the weight itself being high, the same person, you have diabetes, you have hypertension, you have insulin resistance, you have increased clot tendency, and then those patients are very prone to cardiovascular disease, which will lead to strokes and acute myocardial infarction. So in a patient who has high blood pressure, we need to consider which are the patients you need to be screening for secondary hypertension. And mainly, as is shown in the slides here, somebody who has a drug resistance. Yes, you're saying something? Somebody with drug resistance or abrupt onset hypertension, onset of hypertension below the age of 30, exacerbation of previously controlled hypertension, disproportionate target organ damage, accelerated malignant hypertension, onset of diastolic hypertension at the age of 65, unprovoked or excessive low potassium. That leads us to, actually, that's a pointer to screening for secondary hypertension. Which are the identifiable causes of hypertension? The most common we have also related to weight is sleep apnea syndrome. And this one we screen very easily, because Sometimes you have to interview the spouse and then see whether the partner is snoring. Those, of course, some are single. They don't have somebody to tell you, but when somebody snores in excess at night, we tell them the word we usually use ourselves here is to ask the patient whether, when the spouse is telling us the story about the snoring, whether it's loud enough for the neighbors to be awakened by that snoring. But more important, in people with sleep apnea syndrome, those ones are the ones who, during the day, they are very tired, they are fatigued. When they jam like that one in Nairobi, they are going to doze in their wheels and they have to be hooted by the people behind them. They are very tired, fatigued. When they are examining them in your office, they're already asleep and snoring. When they come from church before the food is ready at the couch, they're already snoring. Those type of patients, they tend to have that low oxygen at night. They release a lot of adrenaline, and that causes secondary hypertension. Because the drug induced, those are the steroid and steroid inflammatory we talked about, chronic kidney disease, vascular hypertension. That's when there's narrowing of the arteries to the kidney. Pneumochromatocytoma, that's when you are releasing adrenaline, a lot of it from the adrenal gland, which is hyperplastic. Chronic steroid use and Cushing syndrome, thyroid and parathyroid disease, and coarctation of the aorta. Those are the things which we see as the cause of secondary hypertension. And the side here is the one showing the sites of those secondary hypertension. That's adrenal gland on top of the kidney themselves, renal arteries being narrowed, and even people with like elderly people who have prostatic hypertrophy, when there is a benign hypertrophy and there is obstruction flow of the urine, you may get backflow, and from the ureter, obstructive uropathy, even kidney stones can cause secondary hypertension. So the target organ damage, we have mentioned that before, the heart, the kidney, the brain, the blood vessels, retina, all of them being attacked by the high blood pressure, damage the blood vessels, causing injury and causing damage. So this is a pathological section of a patient who has left ventricular hypertrophy. That ventricle is very thickened, but the thickening is pathological thickening. This is a lot of fibrous tissue. This ventricle is stiff. And a patient with such a ventricle, when the blood is trying to enter the left ventricle, it is meeting a lot of resistance. There's backflow, and this patient has what we call heart failure with preserved ejection fraction. And we find that 50% of people with heart failure today, all over the world, including Africa, including Kenya, they have this heart failure with the preserved ejection fraction. When you do the echo on a patient like this one, we find that the ejection fraction may be even 75%, and normal is 55, 75. But they're already congested, they are having pedal edema, and they need to be managed. And this is the echo section of a patient with left ventricular hypertrophy. The septum is thickened, the posterior is thickened, and this ventricle is very stiff, and is causing a heart failure with preserved ejection fraction. Over time, that heart becomes thinned out. When you do the pump function through the echo, which you're able to measure that parameter called ejection fraction, this may be now, like this patient may be just 20%. This patient is having heart failure with reduced ejection fraction. These are the type of patients where we have many drugs available for them, ACE inhibitors, ARBs, ivabradine, drugs like Euperio, the new ones which have come in that area, and ARBs, ACE inhibitors. They have armamentarium to help them, including minocorticoid antagonists, beta blockers, and this is very much available for them. But the patient who have heart failure with preserved ejection fraction, the only thing we're able to give them is managing their comorbidities like high blood pressure if they have coronary disease, and the only thing which helps them is just the diuretics. So this is the process of atherosclerosis, and usually those people who are 20s, 30s, their cholesterol, their blood vessels are nice and smooth. But as you get older, you reach the age of 40, 55, 60 females, there's already deposits of cholesterol in the blood vessels. And this one, especially, you are somebody who likes being angry, you are somebody who likes those negative emotions, you may find that over the cholesterol deposit, there may be cracks. And those cracks causes clot to form. And the patient like this one now, when the crack occurs or there's an erosion and a clot is forming on top, if it occurs in the brain, that is a stroke. When it occurs in the heart, that's acute coronary syndrome. And acute coronary syndrome manifests as acute myocardial infarction, or what is called non-ST segment elevated acute MI. And those are things which causes a lot of morbidity and mortality of the patient. So again, treating the hypertension, when you're doing the first principle of patient education and motivation, there are many things you need to address. You need to talk about primary prevention and good control. You need to tell the patient the benefits of BP control. You need to involve the patient in setting the targets. You need to emphasize on adherence to the drugs and lifestyle. You need to encourage self-monitoring of the blood pressure. Because there are some people who are just too anxious that when they have a machine at home, even at 3 a.m., 4 a.m., they are still going to measure the pressure because they're anxious. There are some where the machine is an enemy. But ideally, when somebody is measuring at home, the way we do with blood sugars, it also helps in making sure the targets are reached. You need to be empathetic to the patient. You must put yourself in their own shoes. You must do also side effect surveillance, and they must do team approach. And the team approach, the one of important component is the pharmacist, because when the pharmacist is working together with the physician or the doctor, then the patient outcome is better. So the therapeutic lifestyle changes for the blood pressure. What are they? Reducing the weight to ideal, reducing the salt intake, low cholesterol diet, and high potassium diet. High potassium diet, you achieve it by taking out of fruits and vegetables. You need to increase the physical activity. And this would be done when the pressure is controlled. Of course, if you have a patient like the one I'm saying who came yesterday and under pressure of 200/120, if you put those patients to do exercise before you control the pressure, that may cause them to get a stroke. But once the pressure is controlled or is reasonably controlled, physical exercise of 30 minutes, brisk walk, 7 days a week is good enough. And then also we need to also tell them to also do some resistance training. They should reduce alcohol consumption. They should stop active and passive smoking. So somebody smoking near you is not good. And then you should adopt dietary approaches to stop hypertension. This was a study which was done in America and showed that when you take plenty of fruits and vegetables and dairy products which are low in fat and low saturated fat, then that type of diet gives you reduction of blood pressure, almost like 2 drugs combined, about 12/7 or there. And it's one of the things you can do on those people where the pressure is just mildly elevated. So this is the diet, and you can see, of course, some people like wine and they take that as an excuse. Some people say, you know, I take wine because the doctor said wine is good for the heart. But obviously, even the wine, if you take beyond the 1 glass female, 2 glasses male every day, that will cause the blood pressure and will cause a lot of damage, including social factors. But you see that the heart healthy diet, there are a lot of fruits and vegetables. You see fish is there. And of course, like young men, they don't want, sometimes even we hear that when their wives are not giving them meat, they are very unhappy. But this type of diet, when you have fruits and vegetables, a lot of it, will protect you from getting high blood pressure. When the pressure is present, it's easier to control. And it's part of that dietary approaches to stop hypertension. And about the drug principles, that is to know that when you're using single drug, that you lower the blood pressure by 30/7 to 18/12. The DASH diet may reduce the blood pressure for you over 13/6. When the 2 agents are used and you say you have a blood pressure above 150/90 and you want to aim at 130/80, if your target is 20/10 above the target, then you really need 2 agents. And the use of combination therapy is the way forward today. Because if you have a patient where the initial pressure is above 150/90 and is less than 60 years old, then a single drug may not work. Then remember also that ACE inhibitors and ARBs and beta blockers as monotherapy are less effective in the Black population, the one we deal with mainly here, and that the other diuretics and calcium channel blockers are better effective, they are more effective in the Black population. Then when you are choosing your medication, you can use any combinations, and those 5 classes, the thiazide diuretic, angiotensin receptor blockers, or the angiotensin receptor blockers and ACE inhibitors, they belong to one class. You can choose either of them. Calcium channel blockers and beta blockers, they can be used. But note that red light, the combination of angiotensin receptor blockers and ACE inhibitors is contraindicated because they are the same type of drugs, and really the ARBs were really meant to be used for those patients who are on ACE inhibitors and getting side effects. So the armamentarium is a lot, and we have so much available in this country. We are spoiled for choice. We tell patients that when you are choosing the medicine for blood pressure, like when you go to a boutique to buy a dress or a suit, there is so much available for us. The renin, angiotensin, antagonists, all these are available in this country, and you actually spoiled for choice. Remember, ACE inhibitors, about 20% of people may get an ACE inhibitor-induced cough. When that one occurs, then the patient is not identified, they really suffer so much. They'll be screened for TB, they may done CT chest and all those things. But if you actually identify that for the patient, you really help them a lot. And the way we identify the ACE inhibitor-induced cough is an irritating cough. You feel like in the throat, you feel like they want to clear the throat. And when you're seeing the patients, even talking to them, and identifying that when you are a pharmacist may save the patient a lot of misery. And the ACE inhibitors, when they are present, the chance of getting those ACE inhibitor-induced cough is much less. And but still 20% of people who may have get ACE inhibitor cough with, they may get the same also when they use angiotensin receptor blockers. But they are superior in that aspect. In fact, when we are prescribing medicine for blood pressure, we tell the patients that when you use angiotensin receptor blockers, it's like using a Mercedes because the side effects profile is very low in those patients. Beta blockers are there, and of course, we know that many of them, they cause ED, but this one called Nebivolo is actually help people improve the nitric oxide donor, like those sildenafil, there's a PD5 inhibitors, and the Nebivolo is useful in that setting, but generally beta blockers may cause that erectile dysfunction. Calcium channel blockers, yes, we are sport for choice in this country. We have so many of them available, and they are the best, very effective in the Black population. When you see a patient is not being controlled and not on a calcium channel blocker, try to read the reason why they are not, because that may be what you need to make the patient get to the target. Remember, they get edema, and some patients, when they get edema, they think that's the time now they have kidney failure, they have heart failure, and it's usually just the side effects of this medicine, which you may find about 5–10%, and identify it so that when you haven't picked it as the doctors, then you're able to take the patient and they can go back to the doctor to give an application of medicine which doesn't cause that swelling. The Thiazide diuretic are the way forward. They make the ACE inhibitors, ARBs, become more effective in the Black population. We also sport for choice in this country. Remember that Thiazide diuretics are the ones we use when the when the glomerular filtration rate is more than 30. When it's below 30, then you need the loop diuretics. And there we have furosemide, toracemide. We see many patients, especially up country, where they are on the loop diuretics when the GFR is normal. They don't usually work that time, and they need to be on the Thiazide diuretic. Aldosterone antagonists, the spironolactone, epinephrine, they are the most handy drugs. When you are using 3 or 4 drugs, that is the one which should be added on because they create a lot of synergy. And most of those patients may be having actually Cohn syndrome. They may be having overproduction of aldosterone, and that medicine, it may be seen in actually up to 20%. It's usually very useful. Remember, spironolactone is not very nice for males because it may cause breast swelling, tenderness, and gynecomastia, which may be not very good for our men. It may also cause ED, but epinephrine, which actually comes from the same company, is one which was designed for that. And sometimes we use so much Inspira that the stock in Nairobi Hospital are finished because many people, once they know that these are very good drug, it helps the mineralocorticoid antagonist, they are on spironolactone, they know it causes those problems for the men. The epinephrine is used quite a lot. Of course, generics are also available. Central acting, yes, they are there. These are mainly preserved for the patients who are pregnant, but not ordinary people. Adomate is not a medicine to give an executive because it's going to be drowsy when he's chairing a meeting, which is not good for them. But during pregnancy, they are useful. Alpha blockers, we have these many press available in this country. Alpha blockers help us when things are tough. When you're using the 6 or 7 medicines, those are the ones we are using. And there are times when you even know when the corona came, here in Nairobi, also the stocks were finished. They were telling us they are only available from Australia. Many patients suffered, but now I think the stocks are back. Oprazosin, the one which help us when things are tough. Also, these direct vasodilators, hydroxyzine, minoxidil, and those expired minoxidil help us, especially when you are dealing with the chronic kidney disease, and becomes handy. Hydroxyzine also helps in where things are difficult, but these are not the drugs to start with because they have also a lot of side effects. Number 8 is a way forward. Fix those combinations, and there are so much available also in this country, and you also again sport for choice. And really, this is what we should be using for the patients so that we reduce the pill burden. When the pill burden is reduced, you increase the compliance. Of course, these are the beta blockers, and as you go down in the generation, the side effects are less, they are more tolerated, and that generation are the ones who use more than the first generation. And those are the issues about the side effects, I think, because of time. I put that slide so that we just see the angioneurotic edema. This one we see in ACE inhibitors. They may also found in a small percentage of ARBs, and changing those medicine, the patient get better. But this one goes on its own without any intervention. And if the patient is not taking the medication, they keep on getting very frustrated. Because it's a very condensed slide with many medications and the dosages, and I think that we can pass. Just to mention that beta blockers, we need to be careful with people with asthma. thiazide diuretics, you need to consider as a contraindication where there is gout, but it is not contraindication because when you are missing a thiazide diuretic in your armamentarium, that may be the reason why your pressure is not controlled. And using the drugs which reduce the uric acid and managing the gout appropriately will still allow us to use the thiazide diuretics. ACE inhibitors, ARB, we mentioned they are contraindicated during pregnancy. And these mineralocorticoid receptor antagonists, you also want to avoid them when there is low GFR, and also they are also not supposed to be used during pregnancy as well. So during pregnancy, the medicines, when recommendation for blood pressure in pregnancy, women with hypertension who become pregnant or plan to become pregnant should be transited to methyl-dopa, nifedipine, or abetalo. Those are the ones which are known to be safe in pregnancy. But see this red, that if a patient is in the childbearing age ourselves, we try to avoid. Remember, many of the ladies, when you talk to them, they'll tell you that many of the pregnancies are not really planned. They call them oops baby. So the people in the childbearing age are not, as long as they are not having a form of family planning which is very reliable, you should try to avoid using ACE inhibitors, ARB, or mineralocorticoid antagonists, because those ones are teratogenic to the baby. Then for recognition decline, we mentioned that poor control of blood pressure may lead to recognition decline and dementia. And probably this is one of the things used as a motivator to make patients take medication. And about the pressure during surgery, we usually try to avoid ACE inhibitors, ARB, the day of surgery, because they may interfere with anesthetic medication. When the pressure is above 170 over 110, is that the time you should not do surgery. But generally, you are better off when it's controlled well, so that the outcome is best for that particular patient. And I think just coming to an end, this is now probably the second last slide. It is just how do you manage blood pressure? You start with therapeutic lifestyle changes. If that one, the pressure is not the target of, if the pressure is still above 130 over 80, you initiate the medication. And when there is compelling indication that the patient has a pressure below 150 over 110, and that time you may use the other diuretics and inhibitor, ARB. And but when it's above 150 over 90, you need to do drugs. And then, of course, when there is no indication for the medication because there is no target organ damage, there is no, the pressure is not very high enough, patient does not have diabetes. When you measure there's something we call risk score, and you find the risk score is low, then you may just use 3 to 6 months for blood pressure. I didn't mention that even when the pressure is just slightly elevated, is up to 150 over 90. Sometimes that may be just right because of the white coat effect. And those are the patients sometimes you may indicate to do ambulatory blood pressure monitoring. But when you are continuing titrating your medication, you may find that when you're using more than 3 medication and innate is a thiazide diuretic, and the patient is not the target, then that patient has resistant hypertension. That's the time you should add mineralocorticoid antagonists. So I think this is just a flowchart of how pressure should be done, that measure in the office accurately, detect white coat hypertension or mass hypertension, and that when you use ambulatory blood pressure monitoring and home-based blood pressure monitoring, evaluate for secondary causes so that 5 to 10% of people who have secondary causes are identified. You should identify target organ damage, in that patient so that they can be managed appropriately. You should introduce lifestyle intervention. We talked about that. You should identify and discuss the goals with the patient. You should estimate the cardiovascular risk to guide on choosing the drugs, especially when the pressure is not very high, and align treatment with comorbidities. And by the end of the day, what we need is that teamwork, which you people as pharmacists, you are part of it. So the conclusion for me for this presentation is that hypertension is the most common medical condition worldwide, Kenya included. Ambulatory and home blood pressure help in identifying white coat hypertension. The target blood pressure is 130 over 80, those people less than 60, but 140 over 90, those more than 60 years old. Blood pressure in patients should be not over-controlled, so that if you are 60 years and above, should not be below 120 over 70 and less than 60, no less than 110 over 60. Then patient education, risk factor modification, lifestyle changes are important components for blood pressure management before starting antihypertensive drugs. and managing hypertension to target, prevent cardiovascular disease, renal morbidity, and mortality. And the final one is this one of the formulary we give people for health living. And these are very simple formula, which probably you should even put in your pharmacy so that people read when they come there, that the formula, the characteristic of healthy people is that 035 130 530. And the first zero means zero tobacco, no tobacco. You should have anybody who is want to be healthy should not smoke, should never initiate smoking, and anybody who smoke near them should be thrown away very fast so that they don't give you passive smoking. Then walking 3 kilometers, brisk walk daily helps in preventing cardiovascular disease. Taking 5 portions of fruits and vegetables every day is very useful, and that is part of that DASH diet. Blood pressure be kept below 130/80. And when you measure the cholesterol, it should be done annually after the age of 40, 35 years. The total cholesterol should be less than 5. The bad cholesterol LDL should be less than 3. And the last zero is avoiding overweight, obesity, and diabetes, and also avoiding stress, because stress is very harmful to the body and to the cardiovascular system. That's the end of my presentation, Latemo, and I'm done.
Thank you so much, Daktari. That was a very informative presentation. Asante sana. I can see people already asking for the slides and the presentations.
Those ones you provide, we actually have no problem in giving it out. We want people to learn and share. And so through the Boringa, we actually give the slides that you can use them. It's okay. We'll provide them for you.
Thank you, Sana. Thank you, Sana, Daktari. Next, I want to call upon Miriam from Boehringer Ingelheim. They're our sponsors for the webinar today. Miriam, are you with us?
Yes, I am here. I actually want
Sana,
to... sorry. I think my slide went. So good evening, everyone. I'll be very quick. So as Dr. Wanyoike has tried to be very fast so that we can be able to have time for the Q&A sessions. Just to introduce myself very fast, I'm Miriam Washira from Boehringer Ingelheim. And I'm here today to probably now discuss on the product aspect. Yeah, I'm in key account management. Thanks. So are all ARBs the same? Let's see if they're the same or not. So I'll be very quick. These are comparative of the various ARBs that we have. We have Micardis, Valsartan, Irbesartan, Candesartan, and Losartan. So Micardis has 24-hour half-life. Volume of distribution is 500 liters. Trough to peak ratio 92 to 100%. Excretion is mainly hepatic and partially renal, and that's why you find dialysis patients being put on Micardis 40 milligram because we say it's not dialysable and it's metabolized by cytochrome P450. So you can see when you compare, it's the only drug that has been studied and proven to be given once daily because of those characteristics. Then there's one aspect that we like highlighting when it comes to hypertensive patients who are also diabetic. Micardis, actually, studies have shown it's the only ARB that has a higher selectivity of the PPAR gamma. As you know, what's the aspect of that activation than any other ARB? So this is mostly very important when you come to a diabetic patient and patient with metabolic syndrome. So the PPAR gamma is a cellular receptor that has proven therapeutic target in the treatment of insulin resistance, diabetes, and the metabolic syndrome. So as you can see, the various ARBs, this was what was seen when it comes to the PPAR gamma activation, and it's only Micardis that was shown to have the highest. So it has an added advantage when it comes to the reduction of insulin resistance when it comes to a patient who is already hypertensive and diabetic. So as we continue, can you see my slides? Hello?
Yes, Miriam, we can see your slides, yes.
Are they sharing? Sorry,
yes, we can see them.
Stop. Yeah, okay, Miriam, I can see them and I'm following very well.
Okay. Let me first stop sharing. I think there's a hiccup somewhere. Just a minute. Let me share again. Sorry for that. Oh my goodness. there was a bit of hiccup when it comes to my laptop. That's why I have stopped sharing. Let me share again. On your end, are you seeing as if they're moving?
They are not moving. We are still having that one of PPR gamma.
Yeah, that's why I want to share again. Sorry for that. Sometimes these gadgets can decide not to. Good. It was shared. Thanks. Sorry, thanks for the patience. So Mikadis, this was a small study that was done actually just to show the whole aspect of the receptor 2 antagonist was caused as a substantial activation of the PPR gamma. So it was only seen also still on the same small study, which was not even, Boehringer was not involved, to actually show the higher selectivity of the PPR gamma. And to prove that, there was effective measurement of insulin resistance reduction. As you can see, fasting plasma glucose, fasting plasma insulin, the HOMA insulin resistance, and the HbA1c reduction in a comparison between losartan and Mikadis. And it was actually seen, as you can see, the long bar, which was Mikadis, there was a long reduction of change from baseline when it comes to the decrease in insulin resistance, as well as fasting plasma glucose, and as well as HbA1c. So this shows as a plus, if a patient is hypertensive and also diabetic, there's an additional benefit if the patient is on Mikadis, Comikadis, or Twinstar. So this was a comparison of Mikadis 80 milligrams and losartan 50 milligrams. Why we compared the two, it's because during that time, that is 2005, losartan 50 milligram was what was available. So somebody would ask, why would you compare Mikadis 80 and losartan and not losartan 100? It's because losartan 50 was what was available. So we compared with what was available. And as you can see, there's still the additional benefit. If a patient is hypertensive with the metabolic syndrome, a greater reduction in insulin resistance, fasting insulin, and also the fasting glucose, and more so the HbA1c. So this is an additional benefit on a hypertensive diabetic patient. So we have also a comparison of Mikadis 40 and the Irbesartan 150 milligram, and still you can see there was a greater reduction of change of baseline of the HOMA insulin resistance, the HbA1c, the fasting plasma insulin, and the fasting plasma glucose. So this shows you that when you have a patient on Mikadis, Comikadis, or Twinstar, they have an additional benefit beyond reduction of pressure of also reducing their sugars as well as the insulin resistance. What is the Twinstar story? As Dr. Wanyoike has mentioned, he said, now we are going the 2-agent way because the reduction of the systolic blood pressure as well as the diastolic blood pressure has seemed to be more effective, as well as blacks respond well with the diuretics and CCBs in combination with the ARBs. And now this is the Twinstar story, because Twinstar is a combination of Mikadis and amlodipine. We have also 4 strengths of that, which you'll get to see. But for now, I'll show you what the few studies that we've done when it comes to a comparison of a single agent, which was amlodipine, 10 milligram, as compared to the Twinstar, which is Twinstar 45, 40-10, 85, and 80-10. And as you can see, the reduction of blood pressure, that is the systolic blood pressure, was still higher when it comes to the combination of a patient who is on Twinstar 40-10 and Twinstar 80-10. So you can see the reduction of the systolic blood pressure of 23.8 millimeters of mercury and 25.8 millimeters of mercury on a patient who is on Twinstar 80-10 and a patient on Twinstar 40-10. So there is a greater reduction of blood pressure if a patient is on 2 agents as compared to 1 agent as amlodipine. The same case was seen with the diastolic blood pressure. This is in a duration of 2 months, that is 8 weeks. There was still a greater reduction of the diastolic of 19.6 millimeters of mercury. This shows you that 2 agents, a combination of an ARB and a CCB, which is Twinstar 40-10, there was a reduction of 19.6 millimeters of mercury, and also a reduction of 19.6 millimeters of mercury if a patient was on Twinstar 80-10, and of course we are talking of change of baseline from 136 millimeters of mercury of the diastolic. So you can see the patient actually gets to the target of 130/90, which you're mostly targeting for such patients to reduce their blood pressure. So when you have patients who are non-respondent to a single pill combination, to amlodipine 5 milligram, and so you have the single pill combination of Twinstar. So if you compare such patients who on a single pill as well as a single pill combination, there was a greater blood pressure reduction. As you can see on my slide, the diastolic and also systolic blood pressure. So we have the arm where the patients are on amlodipine alone, amlodipine 5 milligrams, amlodipine 10 milligrams, and also when the arm where patients are on the single pill combination, the two agents. So we had patients who were on Twinstar 45, and then patients who were on Twinstar 85, as well as we had patients on Twinstar 45, and also patients on Twinstar 85 when it comes to the systolic. And still, you notice a greater reduction of blood pressure on the patient who on single pill combination of Twinstar 45 and 85 as compared to the arm who are on just a single agent, which is amlodipine 5 milligrams and amlodipine 10 milligrams. So as Dr. Wanyoike said, we are going the two agent well of single pill combination. And as you can see, the effectiveness, especially on the additional benefits that we have discussed on Micardis, that adds to that, who of course maybe could be having additional risk of metabolic syndrome and also pre-diabetic. So if you consider such a patient who is already hypertensive on the single pill combination of Twinstar 45, 85, or 40/10 and 85, they'll have a greater blood pressure reduction as well as an additional benefit of reduction of their HbA1c. So of course their blood glucose will also benefit from the same. But of course, this is the main treatment, the main indication for this drug is blood pressure reduction, not diabetes or metabolic syndrome. This is just an additional benefit which was shown by other studies. Let's go to the patients who had severe hypertension. So these are patients who are talking about a systolic of above 180. We are talking about patients with a systolic above 195, less than 200. We still see a greater blood pressure reduction if a patient is put on Twinstar 80/10, and you can see as high as a high reduction of 49.5 millimeters of mercury. So this was also compared, as you can see, with an arm of a patient who was only on amlodipine 10 milligrams. So you can see a patient who was only on amlodipine 10 milligram as compared to a patient who was on Twinstar 80/10, there was still a greater blood pressure reduction of such patients. So there is also a benefit in great blood pressure reduction, especially with those patients with severe hypertension. Then we have also, this was a study which is called the TIMSTAR Severe, and the TIMSTAR Severe is what compared also the various populations. We had the female as one arm, we had the elderly as another arm, we had Black patients as another arm, obese another arm, and diabetic. Of course, there's a patient who will cut across both. So on such cases, there's still a greater blood pressure reduction if a patient is on Twinstar 80/10. You will have still a reduction as high, especially on the female arm, as high as 48.5 millimeters of mercury. So if the patient cuts across broad, of course, there'll be that high blood pressure reduction, and of course, they'll get to goal because that's what we are getting to, so that to reduce on complications that come with high blood pressure. And now, on my final slides, so we have now the combination of the various Twinstars. We have the Twinstar 45, which is Micardis 40 and amlodipine 5 milligrams. Then we have Twinstar 40/10, which is Micardis 40 and amlodipine 10 milligram. Then we have Twinstar 85, which is Micardis 80 milligram and amlodipine 5 milligram. And then we have Twinstar 80/10, which is amlodipine 10 milligrams and Micardis 80 milligrams. And also we have Micardis 40/12.5, which is Micardis 40 and hydrochlorothiazide 12.5. Then we have Micardis 80/12.5, which is Micardis 80 and hydrochlorothiazide 12.5. Then we have Micardis 40 and Micardis 80. Thank you.
Asante sana Miriam for the detailed presentation. Thank you so much. And I will jump right into the Q&A session. I see we have well over 30 questions, so I will call upon you and Daktari to answer. Miriam, the first question I see is Joel Chebon would like to know the price for Twinstar.
dial the bone, price for Twinstar to the patient or to the pharmacy?
I think this is to the patient because he says Mikadis are prohibited to most middle-income patients. And what is the company doing about the price?
We have, I would say maybe I can mention the prices of Mikadis just to understand when he says it's prohibited to the middle income population. I believe is still very affordable to such patients when you look at what is the cost of the complication that comes with hypertension and lack of well management. So for Mikadis, the price is 2,875. That is the 40 milligram. Then we have Mikadis 80, which is 3,285. Then we have the Comikadis 40 and 80 milligrams. So we have it at 2,875. I believe that is quite affordable to the patient. And then the Twinstar, he asked about the Twinstar. So we have Twinstar 45 and 85. Twinstar 45 and 4010 are the same price. That is around 3,696. And then we have the Twinstar 85 and 8010, which is 4,000. Hope I've answered this question.
Thank you so much. Yes, you have answered it fully. Dr. Wanyoike, someone is asking, do you use your right or left hand when taking blood pressure?
Actually, the standard one we use is the right, but ideally, especially when the patient comes for the first time, you should do both arms because that's even how you can identify a patient who may have coarctation of the aorta. And sometimes patients may have already, when they are presenting, the target organ damage. And one of the target organ damage is the damage to the blood vessels, the so-called peripheral artery disease. So if you are having cholesterol deposit on the left subclavian, then you may find that when you measure the pressure on that arm, it is lower than the one on the right. And so we should, especially for the first time when you're doing like the annual checkup of the patient, we prefer to actually do both arms. And if you find any differences, the actual pressure you record as the actual one for the patient is the higher one, because the lower one could be just kind because there's narrowing of that vessel before it reaches the point where the blood pressure is being taken. And so it is good. Sometimes even if you have a lot of time, sometimes the time is challenging, and that is why you really need teamwork, because when you're working with nurses and they may have more time with the patients, especially when you're in the ward, even measuring the pressure in the lower limbs help in identifying those patients who have peripheral artery disease. But of course, the best marker, which should be also part of the measurements of evaluation of a patient who has a high blood pressure, especially when they are more than 60 years old, to screen for peripheral artery disease, to do what is called ankle-brachial index, where you measure the pressure with the Doppler at the dorsalis pedis in the leg and also in the brachial artery, and do that ratio. And when the ratio is low, then you know the patient has peripheral artery disease.
Okay, thank you for that answer. The next question is, what is the relationship between hypertension and poor COVID-19 outcomes in patients?
Yes, actually that is a presentation which was done in our webinar by one of our senior colleagues and teacher, Professor Ogola, and he reviewed it very well, and it has actually been even analyzed and meta-analysis done. And what has come out clear is that the initial thought that pressure itself worsened the outcome in COVID is not correct. And more of that worse outcome is more related to the same people who have high blood pressure. As we are saying, when you live long enough, you get high blood pressure. It's more related to the age factor. And we know COVID affects the older people more. But unfortunately, that's where you have like almost every, as you get older, has high blood pressure. So the comorbidity of hypertension is not actually considered as one of the bad outcome with the COVID-19. But diabetes is very clear that diabetes patients do badly. Of course, age is a factor. And also the other one, which we really need to work on, and very important, is obesity. People with obesity tend to get a bad outcome. But you see those people who are elderly, people who have diabetes, people who are overweight, they tend to also have high blood pressure. So the blood pressure was found to be a confounder.
Okay, thank you, Dr. The next question is on is there a relation between use of contraceptives and developing hypertension?
Yes, that's a very important question and very important because we have even seen, I know one of the presentation I witnessed was a patient who had resistance hypertension. Remember we said resistance hypertension and you have a pressure above the goal of 130/80. You're already using 3 drugs, including azazide, diuretic, and you're not at the goal. And this particular patient, when they analyzed and checked, was just because he was taking the combined pill. The estrogen-based contraceptives are the ones which tend to have high blood pressure. The medical literature is very clear that if you get 100 ladies who are on oral contraceptive and they're estrogen-based, 5% you have blood pressure from that. Many of them is mild, but others go to the level that is resistant. So one of the drugs which you need to screen for patients with blood pressure is where they're having the combined pill. And that combined pill, if it is present, then you advise them to look for alternative family planning because the gynecologists are able to advise them on alternatives.
Thank you, Dr. Another question is on management of blood pressure in a patient with obstructive sleep apnea.
Yes, that one is a nightmare, but really the way forward is that one is very, very simple. Weight is a driver. And we have seen cases like those. We have patients come here, we find they have high blood pressure, they have diabetes, they are snoring. We get our colleagues who deal with this sleep apnea. We have, like where I am, I'm mid-4th floor in Nairobi Hospital Anderson Center. Above here, we have our senior colleague, Professor Masharia, Dr. Nyaga. They have even, they're able to do those sleep studies for our patients. And most of them require to be done what is called a CPAP machine. And the CPAP machine costs about 200,000. So those ones, some of them I know, when we tell them the driver of all this is weight. Most of those patients with sleep apnea come because of being overweight. Of course, there are a few minority who may have issues of structural abnormalities in the upper airway, and those are the ones the ENT people still sort out by some surgery. But majority of patients who have like probably 90% of the ones with sleep apnea, the way forward for them is to actually have that weight reduced. And those people, because they usually have morbid obesity, their BMI is more than 50. The way to work, and we are already doing those surgeries here in Nairobi Hospital, is to do what is called the sleeve gastrectomy, where you actually make the stomach small. I even saw one lady this afternoon who was sent by my colleague, and she came here for evaluation for weight management so that he can have the balloon. So he's supposed to be put a balloon anytime. You put a balloon in the stomach, there's very little space for food. So even you take just a snack, you are full and don't want any more food that day. So the way really for those people with sleep apnea syndrome is weight reduction. That's what helps them. The CPAP machine, yes, the compliance all over the world is very poor. Many people don't use those machines and they don't like them. They think their spouses are finding them invalid if they're having machines at night. And we don't have studies which are done on using of the machines and overcome the problem of the pressure are very low. The benefit is very low because the compliance is very, very low. And really the way forward for those patients is to have that weight down, and the surgery is the one which gives a good outcome.
Okay, thank you, Dr. The next question is on how to manage high blood pressure developed during pregnancy that does not stabilize after delivery, and the management of blood pressure in patients with diabetes mellitus. What is the preferred antihypertensive for these patients?
Yeah, pregnancy, pressure in pregnancy is a topic by its own, and they actually end up with 4 categories of patients who we identify to have high blood pressure during pregnancy. Usually there is that pressure which is related to the pregnancy itself, which tend to occur after 20 weeks of gestation. And there are those people who already have high blood pressure even before they conceive. And really when you have a pressure identified before 20 weeks of pregnancy, that is just a pressure which most likely will continue after delivery. And then there is the one we call preeclampsia. And preeclampsia is where the pressure sets in after the 20 weeks, and usually is associated with the proteinuria. And the people who have preeclampsia, their blood pressure behaves the same way like when you have septic shock, where you have a lot of damage to the endothelium and the pressure perpetuates itself. Sometimes you even get a DIC picture where you get low platelets, sometimes liver abnormalities occur, and if it's not even controlled, may lead to the level where it is called eclampsia, where the patient is having conversions. And when conversions are present, that patient has a very bad outcome. So for preeclampsia, the real management for that is when the pressure is not being controlled, is deliver the baby. Because once the baby is delivered, that interaction of the placenta and the baby is overcome. Then we have seen cases, we have worked with our colleagues here in Nairobi Hospital, where you feel so sad that this pressure, you have tried your best, you are using 5 medications, you are taking the patient even to the intravenous, the better, the pressure is not coming down, and the way to move is to just deliver that baby who probably is less than a kilo, and is very traumatic because the outcome of those patients are not very good. But sometimes for you to save the mother, the delivery of the baby is a way forward. But those are the ones which are difficult to control. But the principles of management of pressure during pregnancy, remember what we said, ACE inhibitors, ARBs, mineralocorticoid antagonists are contraindicated, you don't use. The drug of choice is actually alpha-methyldopa-adomate, the one we used to use many years ago when you're medical students. That is the one which should be the drug of choice during pregnancy. When adomate is not working, the next drug should be labetalol. Labetalol studies have been done on it, and it is safe in pregnancy. Then after that, you go to the calcium channel blockers, and the one which is studied most is nifedipine. And nifedipine can be used, even this one from colleagues, Bayer people. The Adarat LA, which you can start from that milligrams up to 120, becomes handy. But sometimes we try everything, nothing is working, and the way to move forward is that patient is the delivery. Then there are those ones who get now after, there are even some people who develop that pregnancy-induced hypertension after delivery. And up to 6 weeks, one is at least, and sometimes may even reach a point where they are almost behaving like that one of eclampsia, where they may get even conversions. But these ones are much easier to use because at least you are more momentarium. You can even use the ACE inhibitors, ARB that time, and mineralocorticoid antagonists. Remember what we say, that when the pressure cannot be controlled, the mineralocorticoid antagonists are dactone and eplenon are the ones which become handy. But when the pressure that becomes sustained and you are managing it after delivery, you just manage like any other patient. But you find most of them within 3 to 6 months, the pressure go back to normal and you're able to actually withdraw the medication. But when the patient is overweight, they are more than 35 years old, many of them, we see that that pressure becomes sustained. And it's where you collaborate very well with the gynecologist for future pregnancy. They know there is risk for the same pressure. There are those ones who already have high blood pressure and they want to have a baby. They are also at a very high risk of getting that preeclampsia where there's proteinuria and a very bad outcome. So all those factors you need to tell them. And then if they are planning pregnancy, we switch them to the adomate. But more of this, we try to actually avoid the ACE inhibitors. They are being the people in the childbearing age. But once they conceive, then that's the time you use adomate, because adomate is not a very good drug. You have to use it more than twice a day, sometimes 3 times a day. It causes drowsiness, and I see it's not a drug for the executive.
Thank you so much, Dr. The next question is from Dr. Odede Amos. He asks, why is it contraindicated to combine SCEs and ARBs? And also there's a question on how common is blood pressure in young adults between the age of 17 to 20 years old?
Yes, the reason why we don't combine ACE inhibitors and ARB, they're like the same drug actually. If you look at the renin-angiotensin mechanism, you actually have, you start with that chain which we used to do in Chiromo. You start with angiotensinogen, and through the enzyme called renin produced by the kidney, you get angiotensin. Then angiotensin 1, angiotensin converting enzyme converts it to angiotensin, which now is the one which react with the receptors to cause the changes. So when you use ACE inhibitors, you are just working in the higher chain of that cascade of renin angiotensin system. And so when you combine the two, you are just blocking at a higher level, but being blocked further on. And there are new studies which were done. I think that was even sponsored by Boehringer, where they did a study and found that actually when you combine ACE inhibitors with ARB, you have a worse outcome for the patient because of other factors. And there are times when our colleagues in Reno try to use the combinations of ACE inhibitors, ARB, to try to reduce the proteinuria in those patients who have like diabetic nephropathy. But the studies, randomized control trials on that, I think the study was called On Target. It showed that the combined two has a worse outcome for the patient, and that is why actually they are contradicted. It came from that. I don't know whether Boriga, you can, people from Boriga, Miriam, do you remember about the On Target study? And that one you people did on Micardis and found there was a harm.
Correct. Actually, it actually showed that it Micardis who tolerate this. You cannot use a combination of the
So the reason why the combination is not recommended is that it has been proven it is harmful, and physiologically it doesn't look a very nice approach, because those drugs are the same, only that they are working lower down. The angiotensin receptor blockers work at the receptor level, whereas the ACE inhibitors work at the enzyme level, but they are the same cascade and combination. I think I didn't capture the second question, Dr. Atemo.
The second question was on how common blood pressure is in young adults between the age of 17 to 20 years old.
Yeah, we haven't really done the local studies to say that, but when we even look at those guidelines which they produce, they are for people from the age of 18 years. And of course, with this lifestyle syndrome, which we also perpetuate them to our children unknowingly of weight, we are getting some young people getting blood pressure just because of the weight. And there are some people we even see in this clinic whereby they come in, they are 20, 25. There's even another girl I know who was even in this room where I am about 2 weeks ago, and she's a university student, and she's only 21 years old. And for her, we actually have people like her where it is primary systemic hypertension, because her weight is right. We did have the screening, which usually do as a standard for secondary hypertension for her. And mainly this one includes screening for pheochromocytoma, which we do by that 24-hour urinary VMA and metanephrine. We also do a test, and even one of the patients admitted yesterday, we have done it even today. And it is a test where we do a procedure we call CT renal angiogram. And the CT renal angiogram, which was done on this girl, CT renal angiogram checks for renal artery stenosis, which is one of the causes of pressure, especially in young females, because many of them get what is called pressure of the renal arteries. They get hypertrophy of the muscles of the renal artery, and that causes renal artery stenosis. And the same test, when you are doing it, and our radiologists know, we collaborate together. And I even remember this afternoon, I was talking to one of our radiologists here when they were reading that report for us. When you do a CT renal angiogram, you check the renal arteries. It checks for us even whether there's any obstructive uropathy, the same process. But the main thing is that when they are doing it, they're also focusing on adrenals, to see whether there's any adrenal adenoma. And the same procedure, we also do CT aortogram by the same contrast, because that one also screens for us the coarctation of the aorta. Coarctation of the aorta is when the main aorta narrows before the branching of the left subclavian artery. That's coarctation of the aorta. So this particular girl we checked, and it was normal. We actually put her on a very simple medicine, a combination of a beta blocker with a thiazide diuretic, and she's controlled very well. She's compliant, and you're doing well. So there are cases where we get primary systemic hypertension in those people who are young. But as we said in the presentation, when the patient comes for the first time and the pressure is high and they are less than 40, you should have more index of suspicion during your clinical examination, physical examination, and investigation to screen for secondary causes. And with the weight epidemic in the world, we are getting some just getting on, not like this particular girl we are taking care of, but some we also see here where the driver is just weak.
Thank you for answering that, Dr. I will take 2 more questions. I can see we have way over 40 questions and time is running out. So I'll just ask 2 more questions and then I will hand over. So a question I have seen is on selective systolic hypertension. or selective diastolic hypertension, how to manage those types of hypertension. Also, in the market, there are very many digital blood pressure machines. How reliable are they? Thank you, Dr.
That's a good question. Isolated systolic hypertension, that is a pressure where the systolic is more than 130, but the diastolic is less than 80. Isolated systolic hypertension, studies have been done on this. Actually, we find it more common in the elderly population, and it's explained very well because as you get older, the blood vessels become stiffer and the systemic vascular resistance increases. And it tends to happen that when the systemic vascular resistance increases, then the rise in blood pressure tend to be more of the systolic than the diastolic. But outcome studies on isolated systolic hypertension shows that there's no difference in outcome between isolated systolic hypertension and the normal hypertension. And the targets still remain the same, that you should keep, especially the same figure we said, 130/80 for less than 60, and 140/90, the elderly, so that you can reduce the associated target organ damage, the dementia, the strokes, ischemic stroke, hemorrhagic strokes, the heart failure, the coronary artery disease, which also we didn't emphasize a lot, the kidney damage and peripheral artery disease. So isolated systolic hypertension should be treated the right way. Then, of course, sometimes you may find that the systolic may be getting too low because it may be getting below the 60. And of course, there are not real outcome studies which have really isolated and see now when it is below 60, what happens. But using the same principle, we are saying we should still address it the right way and still aim at those targets, always considering that we also don't make the diastolic too low. Then the other question is about the digital machines. Yes, that's something which we find needs a lot of addressing. And obviously the patients even ask us which is the best BP machine to buy. And out there, you may not even really be able to say this is a proper validated. But ourselves, what we do here, our practice is those patients who have their own BP machines, because our machines here, we calibrate them and make sure they're effective. And we always tell them to come with their machine. We measure the blood pressure with their machine, and also we measure also with ours and see whether they are the same. But that white coat effect is usually the one which makes things change, because sometimes even when the pressure is being done by the patient themselves, they may be so anxious, and that makes it rise and the machine appearing inaccurate. And so the relaxation, the resting, the patient repeating the test, not just accepting the first one, is a way to ensure that it is actually accurate, not the one which just related to the anxiety. But as we may not be able to tell you exactly this is a better machine than the other, but at least ourselves, what we do that calibration and making sure the patient machine is agreeing with ours. And when they're out of the range, then we just tell them to change to another one, and then they come, we verify. But generally, on principle, much as in the management of blood pressure, we find in the guidelines talking about people measuring the pressure at home, because of the problems of inaccuracy of those machines, the state of the patient. Generally, on principle, we don't encourage people to buy those machines. It's not like diabetes. Diabetic patients, any patient we see who has diabetes, we encourage them all the time to have a machine for measuring the sugar, because that sugar is accurate. And when even diabetic call us, because we usually give them a number so that they can call us for the guidance, we trust that measurement of the sugar with the glucometer machine. But the pressure, when it is done and somebody calls us with the pressure, the first thing we always tell them is have it validated. Either coming to an aerobic hospital, casually come to our office, come to a nearest medical facility where it is done in a hospital environment to make sure it's okay. So the encouragement of BP machine, people measuring, we actually don't, on principle, tell them, because we know many patients, because a lot of anxiety, they are not able to sleep, they are not able to go to work, they're just standing all the time measuring the pressure. And I think it tends to be that our people tend to be more anxious than I think out there in Western countries.
Okay, thank you so much, Dr. Thank you for answering the questions. The presentation was wonderful, very informative. Asante sana. Miriam, asante for your presentation. I can see more questions streaming in, but sadly we are out of time. Daktari has said the presentation will be available to all of us. And I would now like to invite my co-host, our communications and event list, Mbau Gitau, to give the closing remarks. Thank you so much, Daktari. I'm Ivy Ratemo. I have been your host for today. Thank you for joining in and thank you for participating. Asanteni sana.
Kindly, I would request the participants to fill in the survey on the chat before they leave the meeting.
Hello, ladies and gentlemen, good evening, and thank you very much for joining us in the webinar tonight. Dr. Wanyoike, much gratitude from PSK, all the way up from the National Executive Council. Today's webinar was amongst the most engaging webinar with more than enough questions, Daktari, that have come from the attendees. We much appreciate that, Daktari. And some of our members are saying that this is among the best webinars they have attended. So, Daktari, we take this honor to say asante sana for hosting us and for being for the wonderful presentation tonight. Asante, Daktari, from PSK's end. Also to Miriam. Miriam, thank you very much for the for bearing with us for the back and forth to ensure that we have a seamless webinar. We are much grateful for the efforts that and also for taking time to ensure that we get the best speaker for tonight. In fact, for me, I was in the background and I've been able to learn quite a lot in matters hypertension, more the current management of hypertension. Asante sana, Miriam, and thank you very much to your end at Boehringer Ingelheim.
You're most welcome.
To our esteemed attendees, thank you very much for attending tonight. I will recognize probably three respected senior members of the profession. Dr. Jane Masiga, asante sana for joining us. Dr. Kiprono Sine, thank you very much for joining us. And also Dr. Ndegwa Jenga from the PSK Central Lift Branch and Dr. Nahil Dev, asanteni sana for joining us. So on the chat box, ladies and gentlemen, I'll request you to go to your chat box and you'll find a very engaging survey by Boehringer Ingelheim. Please go through it and just click onto that on the chat box, copy it. You'll go through it later on after this. So ladies and gentlemen, just a few announcements as we close down for tonight. So I will inform you that we're having our launch of the vaccination certificate program on Thursday. That is a vaccination certificate program that is going to be taught at the USIU University. This is going to be attended by none other also by the Vice Chancellor USIU. So the reason why we're doing this, we're trying to boost the capacity for the pharmacists in the country, and this is to ensure that we are at par with practice. If you look at the UK, pharmacists at the community level are able to provide the COVID-19 vaccine. So we want our pharmacists to be at par. And ladies and gentlemen, if you're able to also look at the current announcements from the Ministry of Health, the pharmacists who have been trained by the University of Nairobi and have now been approved as vaccination trainers. Those are TOTs, trainers of trainers in the county levels. So we want to increase the capacity of the pharmacist as the vaccinator. And having this week as the World Vaccination Week, with the theme that vaccines bring us closer, kindly let's also meet. Let's meet tomorrow at let's meet on Thursday for that launch program. And also tomorrow, HOPAC has requested us to join in for their webinar. It's also going to be sponsored by Boehringer Ingelheim. I will share the link on WhatsApp. And as Dr. Ndegwa says, lililo na mwanzo lazima liwe na mwisho. Kwa hivyo mimi sasa na langu sina la ziada ila kuambia asante na shukran za dhati kutoka kwa kamati kuu ya PSK inayoongozwa na Rais Dr. Louis Mashogu na the CEO Dr. Daniela Munene. Leo tumefika tamati. Alamsiki.